I'm going to turn myself back on. There we go. Okay, you guys can hear me?
Yep, good to go.
Okay, I swear there's a gremlin. I had to do a presentation for the Eastern Region EMS conference today, and like everything was ready to go, and it takes a lot to get me sweating, especially in the morning. And I was in a full body sweat trying to get all the technology lined up to do a remote lecture. Yeah. So anyhow, again, I had everything ready, and it kind of got, so anyhow, we adapt and we overcome, and that's what we're going to do. So it's a pleasure to be here in this beautiful fall afternoon. And I saw that there's about 6 questions sent out, and I had done my research on them, and now I'm going to just have to talk from memory. So, Rick, if you want to just go with the first one about epinephrine, as I remember.
Sure. The first question, and again, all of these questions were submitted through LEMSA's Ask Dr. Reihart page, which is not actively monitored. I usually go in about once a month and look to see what everybody has come up with. So these last 6 were submitted within the last maybe 3 weeks, and they were all submitted by anonymous.
Okay.
Mike, you got something going on in the background. It sounds like somebody's cutting grass.
Yeah. Yeah, of course, I just started. I got it perfectly set up.
Yeah,
so
that's good there.
Okay.
All right. So our first question that Anonymous had submitted asks, why do we bolus, I'm assuming 1 to 10,000 epi, which would be our 0.1 milligrams per ml epi in cardiac arrests, rather than setting up a continuous epi drip for the duration of the arrest?
So it's an absolutely great question. Can you hear me okay?
Yeah, other than the lawnmower. Yeah, it's better now.
Okay, well, we're just going to have to deal. So anyhow, if it gets too loud, I'll figure something else out.
Okay.
The reason being is largely financial, and that is there's not funding available to have pumps on every EMS truck. And so in order to run a epi drip safely, you need to have a mechanical pump. So you're kind of stuck with a 1 in 10,000 intermittent dosage. Epinephrine, just so you guys know, is something that is pretty controversial and goes in and out of fashion. And some people have suggested that at some point it'll be taken off of ACLS guidance. The thought is it enhances ROSC, but decreases overall long-term survival. And the thought there is that there's constriction at the microvascular level of brain, kidneys, liver, all the important oxygen-dependent organs. And so, yeah, you can get the stimulation of the myocardium back, but the body itself dies. But to answer the question succinctly, the reason it is we just don't have pumps in every ambulance. There's really not funding for that.
And that has led to, if you want to discuss, because of that, the prevalence of push-dose epinephrine in ROSC patients. Is that also why we see an uptick in that whole concept of the PDE?
Yes, absolutely. And I'm going to move somewhere else because this guy's chasing me with a mower. Okay, hang on 1 second. I think we're okay now. Yes, that is absolutely why you're seeing an uptick in push dose epi, and I think a lot of residencies are doing it now. We just hired 2 guys, and this one guy he just loves push dose epi, and our ER does not really have that as a pathway yet. So we're working on it.
As with the paramedic program, as you know, I do a lot of listening to EM Crit with Scott Weingard and everything, and they talk about something called as a dirty epi, where you add 1 milligram of epi to 1,000 bag of normal saline, which ultimately will mix down to 1 mic per ml. As a physician, have you ever done that, or do you have the availability of a pharmacist in your ER or have those pre-bagged already? Or do you opt to use another vasopressor in that time frame?
Uh, so, um, so to answer the question, clinical pharmacists would have a stroke to kind of do dirty epi, and you have to have policies and procedures and checks. And so, I have tons of pressors at my disposal. I have dopamine. I can order Levofed, and so there's not the desire, and there's not the desire, nor is there really the safety of just doing that by myself as an independent provider. But I know what you're saying, and certainly that is a possibility.
Okay, because in the medic class, we just had several discussions as we're learning pharmacology, and my students are going out and finding these things. It's wonderful that they're doing it, but again, the realization of some of this stuff workaround doesn't really come to us. But also, if one of my students come to you and say, "Hey, doc, we learned about this in class. What do you think about it?" It's always there, but they're enhancing their education, so it's a wonderful thing.
Well, if you look at where medical errors or medication errors occur, it's when you're formulating medicines or compounding, drips on the fly. And so, does that 1 cc become 10 cc's, or 10 cc's become 100 cc's? And it's kind of rife with trouble. That's why, people give dopamine such a hard time. And, I've been using it for 20 plus 25 years almost. And if you look at the critical care literature and all the young critical care guys, it causes terrible ventricular atrophy. Every time you start a dopamine drip, people go into VTAC, VFib, and die. And I've never seen that. I've seen people get tachycardic from it, maybe a couple ectopic beats, but they're probably going to have them because they're sick as a dog for whatever reason. And so I like my pre-measured medicines an awful lot.
Okay, good. Does anybody have any follow-up questions that they'd like to ask Dr. Reihart regarding the question regarding epi drips during cardiac arrest? All right. Well, I'm going to assume silence is golden on that one. We're going to move to question number 2, Mike.
Yep.
And again, these just bounce around. I pulled these the way they came out of the database. Are there any plans at LGH for allowing EMS providers to call trauma alerts pre-hospitally?
Yes. It's been an ongoing level of discussion, and here's the real reality here: is if I go in the house, the dog can't stop barking when the guy mows. So I either got a dog barking in the house, or I got a guy mowing outside, or I can just walk to the field, which is another option. So anyhow, that's why we're dealing with this. So anyhow, yeah, we continue to have discussions with our trauma team. I don't know if you guys know, but we went through the final stage of accreditation yesterday for level 1 designation as a level 1 trauma center. That would put us in line with Hershey and York. So it's pretty exciting. We should know, I think, by November. And we've looked very closely at our over triage and under triage rates. And so just like any steering a big ship, it takes a lot of turns of that wheel to move just a few inches. So it has been a discussion point. Some people have argued that the comm center should call traumas and not EMS. Of course, I had a stroke when I heard that. But I guess in Pittsburgh, it's done by their call-in center based on criteria. I personally would like eyes on the ground, the people that are there looking at the patient to make that decision. So I think you will see and hear from LEA more openness to ask your opinion. I know Virco's doing that, and I'm doing that. and I'll come right out and say, should it be a trauma or shouldn't it be a trauma, and then follow that direction. Not everybody's doing that. So the long and short of it is, yes, there's discussion about it. Do I think it'll happen? Probably. We just need a little bit more time.
Okay, yeah, coming out here 4 years ago, coming from Pittsburgh, that was quite a surprise to me. The concept of eyes on patient before calling a trauma, that was something new, because we would call them and have the trauma team waiting for us upon arrival. So that was something new, but that's good. Again, congratulations on the accreditation. I know Joanne and Seth and Brian were working very hard towards that. So congratulations.
Well, we didn't get it. We didn't get it yet.
I know, but getting through that process is congratulatory enough sometimes, yes. So does anybody have any questions or follow up regarding the question regarding the EMS providers calling trauma alerts pre-hospitally?
Dr. Reihart, hey, CJ. In your experience of letting the providers call it over the phone now, are you finding they're pretty much on point with their recommendations?
Yes, absolutely.
Okay.
So yeah, I'm a big advocate of it, and when I was out, and I'm going to talk a little bit about why I'm not riding right now, but it's just completely different between being in an emergency room and being in a pre-hospital environment, and it's a number of things. It's it's the car accident next to F&M that gets called in as a 25-mile-an-hour MVA, and when I'm there, the wheel has been ripped off of a Chevy Suburban, the windshield shattered, and sure, it happened at 25 miles an hour, but there's significant damage to the compartment, and it's a 90-year-old lady driving the Suburban. So yeah, being there is much different than the message that gets to the trauma center, and you just get a flavor. I remember I was out in Centerville Road, and it was a guy who fell, but when he fell, it was an industrial site. Like everywhere he fell, he hit a pipe for 30 feet down. Like it was just horrible, and so the initial report was that he fell 8 feet, but he fell 8 feet off of the last pipe, but started 30 feet up. And so just that pre-hospital flavor. Same thing with the drug overdoses. I hear you guys are hurting pretty bad with this kind of concept of compassion fatigue or depression, that every day you come in and you just see the same person overdosing, or you're in the same house with a different address with a mother dead, kids playing, the father upstairs high, and it weighs heavily. And while I see it kind of I've seen it with you guys in the field, but the emergency department, it's a much cleaner. Patient comes in, he hasn't fought, you haven't seen the tragedy of the children or the house. You give him Narcan and out he goes. And so I know it really builds up on you, and that's the glory of being out in the streets with EMS providers. Any other questions?
All right, moving on then to number 3. What are your thoughts on permissive hypotension in the trauma patient?
Yeah, so I sent Rick a nice review article, and I had all my notes that somewhere ended up in cyberspace. So let me just go from my memory. But permissive hypotension is essentially a systolic blood pressure less than 90. Some people say a mean arterial pressure somewhere around 60 to 50, which is still pretty low. But the whole concept is really designed for penetrating trauma. The goal here is there's 2 places that you really don't want to do permissive hypotension. And before I talk about them, what is permissive hypotension? So essentially, we've been taught that anybody that's hypotensive, you go ahead, you bang 2 large bore IVs in them, give them 2 liters of fluid, get that blood pressure to 120 over whatever, 140 over 100, anything over 100. But there's some unintended consequences with that. One of which is causing hypothermia. It can cause a dilutional anemia, meaning you got your 4 liters of blood, and if I stick 2 liters of blood in, to a body that's already bleeding, I can dilute the amount of hemoglobin that's circulating. And then the last part of that is you can disrupt some of the clot that has occurred. You can also create unnecessary hypothermia, which is going to lead to a worsening coagulopathy. So there's a number of moving pieces there. When you just kind of slam in fluids, there's some consequences to that. Now, with that being said, permissive hypotension is really for the first half hour to hour of management of the patient. They've done tons of animal studies, rat studies, where they'll lacerate the splenic artery, get them really hypotensive and hypovolemic. And if you extend this over 2 or 3 hours, or any longer than the first 60 minutes, then you have really, really bad mortality. Then the other thing that you got to think about is who would benefit from hypotension. And so really, as I said, it's a penetrating trauma thing. They have not seen it of benefit in blood trauma. And really the big contraindication is head injury. We know that just one dip in systolic blood pressure or mean arterial pressure in a head injured patient significantly changes outcomes from a traumatic brain injury. So normo to hypertension is really encouraged for, and when I say hypertension, I mean, 120 to 150, not super high blood pressure, but maintain good perfusion. Because if you think about the physiology and the anatomy of the brain and the skull, you got a fixed container. And so if you have a traumatic injury, whether subdural or epidural, you have increasing pressure from the blood compressing the brain. So you decrease that cerebral perfusion pressure. And so that's why it's so important to have good elevated blood pressure or good systolic blood pressure, because if you would let the blood pressure drop, that cerebral perfusion pressure goes down significantly because of the external pressure from the subdural, epidural, skull fracture, whatever. So, so permissive hypertension, good for penetrating trauma. The definition would be a systolic blood pressure somewhere between 80 or 90, or mean arterial 50 to 60. And I know we don't really use mean arterial. Myself, I still like systolic blood pressure. The reason we calculate mean arterial pressure is it really is a better measure of organ perfusion, because you're taking both the systolic blood pressure and the diastolic blood pressure, recognizing the diastolic blood pressure, that's 2/3 of the whole contraction cycle, and coming up with a kind of a perfusion model. So yeah, I think it's good, and we use it, and really just should be isolated probably just for penetrating trauma. Does that help answer the question?
Mm-hmm. I think it did. Anybody have any questions on follow-up on the permissive hypotensions?
And as I said to Rick, I sent out a very, very nice, more in-depth review article, but it really captures all these points. And just remember that brain injured patient really needs to have good solid blood pressure.
What's your thoughts on pre-hospital whole blood, and also the usage of pressors for those head injured patients to keep your CPPs up?
Yeah, so so pressors, that goes back and forth, and so it seems like one day it's in favor, the next day it's out of favor. I think whole blood is probably a more interesting discussion, and we are using whole blood in the trauma bay. The problem is shelf life, and right now donor supply due to COVID-19 is extraordinarily low. People are scared to go out and donate, and so there are real benefits. And if anybody has a question about whole blood, essentially, whole blood is what I'm going to take out of my arm and give to you, or you're going to take out of your arm and give to me. Back when we started transfusing blood, we found that the shelf life was much longer if you would separate the blood into its component parts, i.e. plasma, platelets, and red blood cells. So you can sit on blood for a much longer time. Whole blood, as I remember, I think it's like 6 to 8 days, so significantly less shelf time. But what you're doing is when you give the whole blood, you're giving all the clotting factors back. You're giving everything that is a natural blood. So there's much less issue with coagulopathy. Does that answer your question, DJ?
Yeah, it does. Thank you.
Sure.
So, Dr. Reihart, it's Rick. To follow up on that, where do you see blood, if at any time, coming into the Commonwealth?
So our helicopter services are working on a project now, and I think have some capacity for that. UPMC is doing that that I'm aware of.
Okay, good. So, anybody have any other follow-up questions regarding that discussion? All right, number 4, Dr. Reihart, how has COVID impacted your role in the ER, and with that, what has changed for you, as well as how has it impacted your role as medical director here at Lancaster EMS, or has it, or has not?
I didn't even know COVID existed. What
Oh,
the
okay.
hell? What are you talking about?
I'll get you some links for it.
Yeah, thanks. Hang on a second. So yesterday I presented at grand rounds at LGH, and so the basis of these grand rounds were, and it's kind of neat that I was invited, but it was the director of the ICU, Jan Bergen, CEO, Mike Rachinsky, Chief Medical Officer. Well, there's one less deer in the yard. What else is going to happen today? So anyhow, a number of the things, Dr. Wu, who's a trauma surgeon who survived COVID, and one of the ICU nurse practitioners, and then a geriatrician or two. And it was really moving, and I can certainly forward you the link, but it was kind of cool that they asked me as EMS medical director to provide my comments on what it meant to me. Now, the challenge was that every person only had 5 minutes to discuss the largest pandemic and the largest natural disaster in essentially our lifetime. But if you will indulge me, I'm just going to give you a couple thoughts of what I offered yesterday. And so essentially what I said is, before I begin, I want to recognize all the EMS providers who have paid the ultimate sacrifice and succumbed to COVID-19. Looking at the numbers, it's about 33 people that were truly EMS and died of COVID, 3 of which were in the Commonwealth. And these are not completely accurate numbers, but close. If we add in fire and police, it's really a substantial number of people who have died. So God bless them and their families. I also want to acknowledge Deb Hess, RN, who is their infectious disease nurse. She's answered every one of my text messages in the following manner. Deb, I have time for a question. Yep, day and night. Every month, every day, she was there. Joe Contra, who's the chief of infectious disease, for steady expert guidance and EMS support. Alice Yoder and Rosemary Search for their public health commitment. Our medical staff and leadership team, and also Carla Lead, who was really key to our EMS collaboration. So when Dr. Deshpande, who was the lead physician of this project, asked me to discuss the EMS response to COVID-19 in 5 minutes, my initial impression was, hey, that shouldn't be too hard. However, nothing could have been further from the truth. Due to the miracle of the internet, a quick Google search told me a 5-minute speech typically consists of 750 words. So 750 words to describe the EMS response to the worst natural disaster in a century. Perfect. Thanks, Swapno. I was really torn between 2 titles for my lecture, the first being Building the Airplane as It Flies, or number 10, Global Pandemic. I chose the latter as it epitomizes the disaster and mass casualty lectures I've attended over the past 25 years. Typically, all these lectures would discuss in detail the current threats to our country, including suitcase nuke, EMP, radioactive dirty bomb, anthrax, ricin, smallpox, bubonic plague, Ebola, blister and nerve agents, and even tularemia. Then, with a nervous cough, the presenter would vaguely mention the possibility of a global pandemic, followed by a quick, thanks for your attention, please turn in your evaluation and have a safe trip home. So with this preparation, I walked into an urgent meeting near Harrisburg on March 16th to discuss the COOP plan. Pennsylvania Department of Health delegates EMS regulatory control to 13 regional EMS councils. I've served as South Central Pennsylvania's regional medical director since 2002 and provide medical direction for 8 counties, including Lancaster, nearly 2 million residents, 6,000 EMS providers, 8 911 centers, 159 EMS agencies, and 300,000 EMS calls, about 65% of which are transported each year. Until this meeting, I'd only heard the term COOP mentioned once in 17 years. The COOP plan stands for Continuity of Operations Plan for a Catastrophe Disrupting or Destroying EMS Care as We Know it. The message was grim. We were told to expect a loss of 30 to 50% of our workforce in the next 60 days due to COVID-related exposure, illness, or death. Even worse, the strategic stockpiles of EMS supplies and PPE, which were bolstered for Y2K, were now 20 years old and rife with decay. They had also been either relocated to a never-never land. No EMS agency had more than a few weeks of supplies if they were lucky. Unfortunately, if PPE supplies were located and usable, they could be confiscated and redistributed to other areas of the Commonwealth, like Philadelphia or Pittsburgh. Charles Dickens could not have summarized the situation any better with the opening sentence from A Tale of Two Cities. It was the best of times and the worst of times. It was the age of wisdom. It was the age of foolishness. It was the epoch of belief. It was the epoch of incredulity. It was the season of light. It was the season of darkness. It was the spring of hope and the winter of despair. We had everything before us. We had nothing before us. We were all going direct to heaven. We were all going direct the other way. I'm sure many of you in the room had similar experiences, and our days became a blur of virtual meetings beginning early and then deep into the night. I was granted a supreme blessing by being the physician lead of a group of men and women who are used to working long, stressful hours for low pay, little recognition, but to embrace a powerful professional mantra to adapt and overcome all challenges, adversity, and obstacles confronted in the pre-hospital environment. EMS providers are not just lifesavers, but innovators and expert problem solvers. They truly are modern day knights. And so with this positive mindset, our EMS providers used amazing ingenuity to respond to the shortages and threats of the pandemic. Paint sprayers were purchased from hardware stores. And, you know, I missed one sentence of this, and I just want to say it for you. And this, I don't know if I said it or not, but I was granted a supreme blessing by being the physician leader of a group of men and women who are used to working long, stressful hours for low pay, little recognition, but who embrace a powerful professional mantra to adapt and overcome all adversities. And so with this positive mindset, our EMS providers used amazing ingenuity to respond to the shortage and threats of the pandemic. Paint sprayers were purchased from hardware stores and transformed into medical-grade disinfectant sprayers. Shower curtains became a barrier between the ambulance, passenger, and patient compartments. Plastic boxes were wired for UV light to disinfect stethoscopes and other equipment. The same shower curtains were also transformed by seamstresses into fluid-impervious gowns. My best description of the EMS response to our COVID-19 challenges would be described them as a heroic symphony of innovation, fluidity, and teamwork. Again, truly modern-day knights. I would be remiss to fail to mention how effectively LGH supported our EMS colleagues with weekly virtual meetings with hospital leaders and 24/7 telephone access for any questions, concerns, and guidance relative to COVID-19. I am unaware of any other health system in South Central Pennsylvania who offered this level of support. EMS was also provided a key public health role in the Amish and Plain community. We were able to leverage the support of our Plain and Amish and rural EMS providers to be a conduit of information on social distancing, PPE, and COVID-19 facts with our wellness team. In closing, I shared a quote, which I don't have right here, but essentially we were on the telephone call with Paul Stoltzfus, head of the Amish Safety Committee, when he quoted Martin Luther from 500 years ago, one of the founders of the Reformation, and ultimately to the Anabaptist religious sects, including the Amish and Mennonite religions, encouraging social distancing during the bubonic plague. So that was my speech. But I think I want to let you just with one other thought, and that was during this pandemic. I didn't know what was going to happen, and you guys didn't know what was going to happen, and it was super scary. It was super scary for the frontline providers and also for families. I never was in the military, a regret that I have, but I did get a sense of the awful responsibility it is to send people into harm's way. And when I went to work, the hospital gave me this paper mask and said, wear this paper mask and you're going to be fine. And I think we did it. I mean, we followed some very rudimentary guidance, and we washed our hands. We added eye protection, and so we have been very, very blessed to have not been dealt the blow that was suggested. It's not over yet. We're starting to see an upsurge in it. It looks like the vaccine is still some months away, probably in the springtime. We don't know how long that immunity is going to last. But to answer your question, I think COVID-19 has changed all our lives, and probably in some ways for the better. I think we were very poor at infection control. I just heard that we got a grant for an aeroclave. We would have never been motivated enough to do that without the pandemic. I think we'll probably end up using masks probably for a long, long time to come. We're going to have much more attention to hand hygiene. But during the pandemic, I was actually told that the Amish were going to go back to church. And I didn't have time to talk about this yesterday, but I just want to let this with you. And so I was given the name of a bishop in eastern Lancaster County. And I was told that he was one of them, that was a decision maker, that they were going back to church. So I got all the literature from our wellness people, and specifically on singing. And the Amish love to sing, and I'm a terrible singer, but I love to sing when I go to church, and I think I feel closer to God. But singing is one of the worst things you can do to spread the virus. So I went out to see him, and his store would be the Amish equivalent of like Home Depot. I mean, it is impressive. And I went in, and he was probably one of the grouchier Amish guys I've ever met. He didn't stand up. I gave him the information that I had. He said he would look at it, and I left. He never shook my hand, as social distancing was. I walked out, and I drove home. It was about an hour. I found out the very next day that he had taken my advice, and he canceled church. And they had stayed out of church probably 3 to 4 weeks, but it was getting closer and closer to Ascension Day, where it's a very important religious holiday, and they share a common cup of wine made by the bishop's wife. And so I went back out about 2 weeks after I'd met him to take hand sanitizer and drop that off as a good faith effort. And then I went back out again, and he wasn't there. And I was supposed to go out again to see him, and they said he's dead. He died of COVID-19. It kind of puts in perspective. And I know you guys have seen this day and night. You bring the people in, you take them home, you bring them in, you take them home, and it weighs on you. I would say that the way we did this, probably for a lot of the elderly, was probably not the best thing to do. Before COVID, I could just say, hey, somebody really looks sick. I think they're going to end up having a pneumonia, or they're going to have this or that, and we can put them in the hospital. But we had these strict guidelines where, if you pick somebody up at a nursing home and there's 3 other people in the room and they weren't hypoxic, that was really the only criteria that we had to admit them to the hospital. So you'd send them back to that room of 3 or 4 people, and then of course they all contracted it, and it was devastating. So again, I think that my first title, we're building the plane as it flies. We're learning more and more about it, and certainly there were lessons learned. I think our therapies are much better than they were. We know so much more about it, but it's still not to be discounted. It's a deadly disease. So that is a very long-winded, kind of emotional answer to a question about COVID-19.
All right. Thanks, Dr. Mike. Anybody have any follow-up on what Dr. Reihart discussed? All right. Now this question here requires you to get your 8 ball out, your magic 8 ball out, and
Yep.
once would like someone anonymous would like you to um, talk a little about changes that you anticipate with EMS in the next 1 year, 5 years, and possibly 10 years, looking that far down. And what are some of the things that you would, if an EMS medicine futurist that should be planning to do with those 1, 5, and 10 year markers looking ahead?
Sure. Yeah. So I really appreciated the question, and I took a fair amount of time thinking about it. And anything I say, please don't take that as a that I'm endorsing it. When somebody asks me, I'm predicting things that may be positive and negative for EMS or for ALS or BLS services. But if all of a sudden this conference call ends in like 1 second, ultrasound. I just want to get ultrasound out there. I think that ultrasound has amazing potential, and I want to put that at the top of my list because it is a tool that I was not trained on in residency. All new residents have to have a very, very extensive training program, and I think that ultrasound for physicians, and I think for even EMS providers, will become our new stethoscope. The reason I like ultrasound so much is, first of all, it adds so much more to kind of your diagnostic acumen. In the third world, you can diagnose intracranial pressure, tumors, fractures. You can distinguish between CHF and COPD, pneumothoraces, and the technology just continues to get better and better and cheaper and cheaper. There's a device called the Butterfly IQ, which is a device that interfaces through your smartphone. I believe it goes through I think it's just exclusive to the iPhone. But for $2,000, you have a pretty state-of-the-art ultrasound machine. And where I see it really, really a benefit early on with not much training would be for resuscitated cardiac arrest. Again, being in that pre-hospital environment is very key for me. Andy Gilger and I had a cardiac arrest, and I forgot, it was a witness arrest. The guy goes down, and it was essentially an ACLS mega code. Of course, the whole family's in the room crying. We don't have that sterile environment in the ER where the family's with the chaplain. No, everybody's there, and this is prime time. They're watching, is this guy going to live or die? And the question is, can I feel pulses? Can I not feel pulses? Is there myocardial squeeze or not? And so I was like, God, I would love to have an ultrasound machine, but I didn't. And ultimately, we resuscitated the patient. We transported him to the emergency department. He survived and was discharged neurologically intact. But to have that tool of ultrasound would have been so much more reassuring. So there's a pilot project right now in southern York County. And of course, things in Pennsylvania can take quite a while to get a project moving, but they are moving in the right direction. They were initially going to use a different device, but I think they went back to the Butterfly IQ. And so ultrasound, I would like to see in the very near future. Just starting out for looking at cardiac arrest, or I can't feel pulses, but it's a heart squeezing. That's all. It's down and dirty. So that's one thing. I think that another cool thing is community paramedicine. Community paramedicine, when you look at what Lancaster EMS is doing, we're light years ahead of 95 to 99% of agencies in in Pennsylvania. And really, that's the leadership of Carly and Bob and Jerry. And just take a look at what they're doing now and just imagine what they could be doing 5 or 10 years from now. So I think that will continue to grow. Workforce, and then the last question also goes with workforce issues. And we're going to continue to have problems with workforce until we can address how lousy wages are and, to make it an enticing career. And, we see in other areas like Maryland where there's a pension program and a retirement and the light at the end of the tunnel. And unfortunately, Pennsylvania with low wages is going to be really, really hard to not only attract but keep the talent that we have right now. So I think in my head as a leader, some of the things that we can do to kind of offset that is to be cutting edge at what we do, to be the best at community paramedicine, have the best technologists. I mean, we've seen such tremendous success with mechanical CPR, and just having integrated medical leadership, have a health system that's involved. And I do think that probably going forward, you're going to see much more health system involvement in EMS, and I would not be surprised. It seems like every 30 years, mass trousers come back or something else comes back, and I would not be surprised if there would be a more larger role for financial support of EMS by health institutions. So that would be something that I would predict. Resuscitation of cardiac arrest patients, extracorporeal membrane oxygenation, ECMO in the field, and essentially what that does is you take somebody, their heart, if you think about an ankle sprain, right? How many people can walk in their ankle for the first 4 days after an ankle sprain? Same thing if you have a myocardial infarction. It takes a little while for the heart to figure out, is it going to get better or not? So it's kind of a stunned myocardium. So by using ECMO, extracorporeal membrane oxygenation, you take the heart out of it, you take the lungs out of it, and you do all the oxygenation and cardiac support through a heart-lung machine. After 3 or 4 days, the heart starts to work a little bit better. And so if you look to areas like Japan, South Korea, and some other places, there's really amazing statistics of survival using ECMO. Now, here's the thing, though. In order to have an ECMO program, you got to be a pretty big hospital like LGH. And up until a couple of years ago, we sent all our ECMO patients to Hershey. So what do you do if there's small community hospitals that don't have access to ECMO? That's where you're going to see mobile EMS ECMO units. And I think Minneapolis is doing that right now, where you have a resuscitated arrest, you send a team out, they hook them up to ECMO, and then transport them to a facility to maintain that. The technology of ECMO used to require a perfusionist who made boatloads of money just to run all the machines. Now there is a prefabbed machine. I think it costs like $13,000, but it does everything the perfusionist did, which makes it very smooth for EMS. Another thought that I had relative to the future is the use of drone technology. And I think that there are several benefits to drone technology, but I think it would be cool to have an eye in the sky to see what that accident looks like before I get there. Are we going to be able to deliver an AED to a cardiac arrest scene before EMS can get there or get through traffic? Can there be a delivery of medications through community paramedicine? If somebody can't get to the pharmacy, can we drop it off by drone? I mean, all these things are kind of Buck Rogers in nature, but still possible. And then the last thing, which I know is kind of controversial, and remember, I'm doing all this from memory. I had notes, but I'm doing my best, is probably there will be less emphasis on ALS because it's just going to be so hard to maintain ALS providers. And I think we're seeing that now with advanced EMTs. I don't particularly care for it. I think that advanced EMTs have a place in a rural environment like Wakefield or New Holland or in Grand Canyon, Pennsylvania, where you got more bears than patients or more cows than patients. But unfortunately, due to market forces, even your big cities are pushing more towards a BLS model or an intermediate model than advanced life support. Certainly, probably a step backwards in many aspects. But you asked me what I thought was going to be the future, and so I think that probably summarizes what I have.
All right. Well, I think you already touched on. Does anybody have anything else they'd like to fill in on the futurist discussion there, on where we see ourselves within 1, 5, and 10 years?
Hey, Mike, it's Jerry. I had a question. What do you can you talk a little bit about Pulse Point? It's used elsewhere. We've had some chatter about it locally. Do you see that as a reality in the near future?
Yeah, so Jerry brings up something called Pulse Point, which was owned by Physio, and essentially is a crowdsourcing tool for sudden cardiac arrest. The way it works is you download a Pulse Point app on your phone, and if you think about it, we're all paramedics, doctors, EMS providers, nurses, and I can be in aisle 10 at Giant, and in aisle 2 there can be a cardiac arrest, but I'd never know it. Same thing with Walmart or the mall. You could be at Boscov's, and then Bonton Mall, or what used to be the Bonton Mall, there's cardiac arrest. Well, I know an awful lot about it. You guys know an awful lot about cardiac arrest, but the lay people don't. So this app would notify people that are close by, hey, there's cardiac arrest in aisle 10 at Giant. You go over and, you begin the CPR, you ask for AEDs, you get 911 involved. And it has been quite successful in some locations. I was hell-bent to be the first in Pennsylvania to get Pulse Point, and I wanted to be the first county. I worked, I can't tell you how many hours to get it to happen. The attorneys from LGH, the attorneys from the county worked on it very hard. The 911 center broke down all the firewalls. We were ready to flip a switch, and that was the but. And the but was Pulse Point would not budge with its contract. If you're a lawyer is, they all have to argue. I mean, that's the way that's their life. If they get a contract, well, let's change, this, and this. Pulse Point would not bend at all. They refused. They said, this is a contract we give to every metropolitan area. This is what we have. Take it or leave it. It was a deal breaker. It was a deal breaker for LGH. It was a deal breaker for the county. Part of the thing was, and it was really not clear initially, and I think I've said this before, data mining is money. They say data is the new gold. And so part of Pulse Point was to data mine, not just EMS calls, but they wanted access to fire and police calls as well. They wanted time of dispatch, everything that you could ever assimilate from a 911 center. That was part of the package. Then the icing in the cake was a price tag. I want to say $300,000 for 3 years, maybe. It was a big nut to crack. Now, the Heart Stroke Foundation said, we'll come up with the money, but we could not get past that legal impediment. So now, fast forward 5 years to now, and where are we at? Pulse Point is in Chester County. Pulse Point is in Pittsburgh. It's in Lower Delaware. It's all over the place. And, there's mixed reviews. Some people like it, some people don't. But as technologies continue to move, and we have other things that are now a priority in addition to the treatment of sudden cardiac arrest, namely stop the bleed or other traumatic injuries. So there are, I think, some other products out there that may give Pulse Point a run for its money because, say somebody has a arterial laceration in aisle 10 and not a cardiac arrest, we could crowdsource those persons that have a tourniquet or know something about bleeding control to provide care there. So that window of opportunity is there, and it's coming back. Mike Peck from the Heart and Stroke Foundation is pushing very hard. We have funding. I hear that Physio may not own the product anymore, or whoever was so stalwart and stringent about changing this is more flexible. So there is a possibility, and I support it. I mean, it may be an expensive tool just for cardiac arrest, but really we know that the benefit, the long-term benefit of survival is getting that bystander CPR, and that's what Pulse Point will allow us to do. So I support it. I know Daryl Fisher has been working with Mike Peck, and I think it's going to be a hard nut to crack the second time because there's such a bad taste from the lawyers that did the first contract, but it's worth a try again. Does that answer your question?
Does that answer your question, Jerry?
Yes, thank you.
I want you to know, just listen. Do you hear any background noise? There's no dogs barking. There's no mower running. There's no deer being killed behind my house. So we could talk for another hour. And by the way, while I was out here, my wife came out and just let me know that my dog just ate a bushel of apples while I was outside of the house. So anyhow, life is good.
All right. So the last question here, I'm going to say that you've already answered it when you were discussing number 5 when it came to challenges when it comes to human resources. Number 6, basically, just to reiterate, it says that with multiple staff openings, why do you think that is? And you had expounded on payroll issues and all that, but it says that we also see that as an industry trend currently. And unless you have something else to add to that, what else do you think needs to change to help with recruitment and retention?
So I think that there's another thing that's non-economic, and that is COVID-19. I mean, you know, we've really upset the apple cart, and we went from a career with certain risk factors to now real lethal possible risk factors. And I think that people are saying, hey, I can make this amount of money, at Starbucks. Why am I doing this? I think more and more people are using like the EMT program. If you look at the graduates of EMT programs, like 85% of them use it as a stepping stone for something else, either for industry or to look good in the resume or to do something else, and really not get into the down and dirty EMS. So what do we have to do? We can keep talking about pay, but if we can raise that pay, that would be great. How can you do that? You need to money's got to come from somewhere. So it's either going to come from the government. There is no money from the insurers. The insurers have kind of thumbed their nose at it, although things are getting slightly better, but not much, or from health systems. And I think that health systems are going to probably, in some areas, realize and are starting to really realize the importance of EMS, and may be able to share something, whether it is a feeling of camaraderie that you're part of a bigger picture, not just of an EMS agency, but of a global health system, providing multiple opportunities, maybe a workflow between EMS, and as you get older, maybe transition into something else, whether it's a tech position in the emergency department, or something in community paramedicine, or some related field. Perhaps if it's a university that has affiliated educational things, that there can be some tuition remission or sharing. But somewhere, the breaking point is I'm aware you guys are working 2 jobs to make ends meet. I mean, it's horrible, and hopefully, there's some discussion about maybe an EMS tax through a collaboration of municipalities, and actually, instead of talking about, oh, woe is us, we can't make any ends meet, actually pay EMS for what they're doing, and it's providing 24/7 life-saving care. Other places have had an EMS tax. Anytime you talk about tax, it's like the worst thing that can ever happen. Nobody wants to pay more, but we're really at a tipping point. And so in order for things to get better, something has to give, and it's not, we're up against a wall. We can't do much more. You can't get blood out of a rock.
All right. Does anybody have any follow-up on that discussion?
There's one topic that was not on here. I know we're getting close to the 3:00 hour. So, and that is under and over trauma triage. We talked about it before, a little bit about can people call trauma alerts, but I can't stress again the issue of the frail population. So we looked at the number, and the number is right around 64. So when you're 64 or older, some of these really, really rudimentary mechanisms of injury, a fall from standing, can create some life-threatening injuries. We had a situation, it was a LEMSA medic called in and said, hey, I think this guy should be a trauma alert. All that happened was a car bumped him and he fell down, but let's make him a trauma alert anyhow. And he was 71 years old. And truly, the guy says, no, the car was only going 5 miles an hour. I just fell down. And when we CAT scanned him, he had everything broken. He had like 5 rib fractures. He had 4 transverse process fractures. I believe he had a subdural hematoma. So just when you, especially in this frail population, 64 and up, little things can be terrible things. And so you're not going to be in trouble or be dinged for throwing a big net, because the longer these people sit in the ER, the longer it takes to get to their diagnosis, their mortality is significantly worse. So that's all I got. So thank you for your patience.
All right, everybody. Dr. Reihart, thank you for your time. Does anybody have anything else that they'd like to pass by Dr. Reihart before we get out of here and sign off, or until the next Ask Dr. Reihart session? All right. Again, they say silence is golden, as Dr. Mike said. He's got his lawn work's done. The deer have been harvested, quelled. All I was waiting for is to hear a big boom behind it. I'm like, oh, okay, look, they're mining now. Where brakes or something going off. So, all right. Well, Dr. Reihart, thanks again. Everyone, thank you for taking an hour out of your day. And Con Ed will be up here probably within the next 24 hours. As long as you put your Con Ed numbers in the in my chat, I'll be able to get it for you. And this recording has been recorded. If you were on crew or missed something, I will download it, process it, and get it up on Planet here within the next couple days. All right, everybody.
Thank you. See you. Bye-bye.
Have a good day.